I'm doing my third year in pediatric residency, but a brief background about myself is I worked as a medical officer in the pediatrics department for 3 years, then was full-time medical officer for the pediatric hematology oncology here in Botswana for about 2 years. Before then, I started my pediatric residency. So pediatric oncology is very closer to my heart, and that's why I felt like I should do a presentation on this. So I know the group is Radiology Without Borders. I'm in no way going to share any images. I have a disclaimer, and my disclaimer is I have no idea on how to interpret any radiological images. So I have to trust on people like a lot of people on this platform for interpretation. So this book here that you see is actually a book that I stumbled across when I prepared this talk. And I'm happy to share the soft copy of this book. And it's actually a good book, but it has a lot of radiology terms that I think a lot of you guys who are in this platform can actually understand. For me, it was a lot of Greek in it, but I think a lot of you guys can benefit from it. The good thing about it is talks about imaging modalities, why you choose which one you choose and which one is more beneficial. We know that a lot of images, especially those with radiation, actually have in a way have long-term complications and all. And I think it's actually a good book. So to start off with my talk, I'm just going to give a brief overview why I feel this talk was important. And actually this talk is more pointed towards the role of radiology in pediatric oncology. So just as an estimate, and actually these are statistics from the WHO, 400,000 children actually worldwide are diagnosed every year. And these are estimates, I think, from about a year or 2 years ago. The numbers may be increasing. And actually, this is not a very big number compared to children with a lot of other conditions. But the biggest problem comes from the burden of disease in these children. And the most common type of cancer in kids is leukemia. And this is actually something that is the same actually from anywhere in the world that you are from, a lot of studies that have been done, whether be it here in Africa. Here in Botswana, there was a publication that showed the same findings. You go to the Western world, Europe, this has been a worldwide trend. And one thing that I think we all should know is there is certainly no screening or prevention for a lot of childhood cancers. I think we need to understand that there's a big difference between adult cancers and childhood cancers. A lot of childhood cancers, actually, the cause is unknown. And except for a few which are actually associated with different viruses, things like lymphomas, which are associated with EBV, Kaposi sarcoma, we know it's associated with HIV, and a lot of other virus dependent cancers such as HCC, which is associated with hepatitis B. But one thing for sure is a lot of other cancers in children, the causes are known. So in terms of preventing for childhood cancers, what we try to do is recognize them early, refer them early, and try to treat early. But we know that certainly there is a lot of difference in terms of survival. There's a statistics from the WHO, and whenever we say childhood cancer in the WHO website, this will come time and again. And this is the 80-20 difference. We know that in high-income countries, we have up to 80% survival. And actually, some cancers are more than 95% survival rate in high-income countries. But a lot of low and middle income countries in our settings here, especially in Africa, South America, Assam, the survival is quite low, up to 20%, 30% in some. And actually, this is just a general estimated survival, but the survival rate is certainly different from diagnosis to diagnosis. This is just the general sense. So based on this, this actually shows the burden of disease, especially in low and middle income countries. So what is our role actually to diagnose these kids quite early, enroll them for treatment quite early? And actually, according to the WHO, survival, especially for childhood cancer, and I think this may apply to a lot of other childhood diagnoses, it's your geographical location, like where you are born, determines whether you survive or you don't survive. And actually, this is something that a lot of the childhood cancer world that are trying to aim at. So I think these are some of the problems that we have in low and middle income countries. Number one, the delayed diagnosis. And if you look at a lot of studies, they show that the delay in diagnosis comes from the poor recognition of early signs of cancer in children. They're not like adults. As I said earlier, there's quite a big difference. So the delay in diagnosis comes from early recognition. There was a study done here in Botswana, and I think another one done in Ghana that has been published, and a lot of other settings where there was a survey that showed that a lot of people actually had not actually received, a lot of people in clinical practice, especially those who are in primary healthcare settings, they have not actually received proper education or training in childhood cancer recognition and management. So that comes from there. And the other part is actually access to a lot of diagnostic tools, like the imaging and things like that. That causes delay in diagnosis as well. And the inability to obtain accurate diagnosis. There's a serious shortage of access to histopathological access and things like that. And then the other thing is accessibility to therapy. A lot of countries actually, especially in low-income countries, access to therapy is one big thing. And there's a lot of partnerships that have been established where countries from high-income countries, they develop relationships with low and middle-income countries to actually provide access to therapy. And then treatment abandonment. This one is where you have a child or a patient that is diagnosed, and then they do not complete their treatment because they abandon their treatment for many different reasons. There are actually a lot of studies also done on treatment abandonment and its different causes. And the other thing is, those kids who enroll into treatment, a lot of them, they die from toxicity related to the drugs that are administered for treatment. So you'll find out that a lot of studies now, they are more focused on providing supportive care for kids who are in cancer. And this is another big thing in our settings as well. How we monitor the toxicities, how we manage the toxicities, and access to other supportive measures. We know that, for example, cancers that require a lot of blood and blood products transfusions, it's a challenge where you can have a country in the public sector not having a lot of sufficient blood products. So I stumbled across a publication new, but they quoted a study that estimated that around the world, actually now, around the world, more than 2/3 of the world population have no access to basic imaging services. And it was a quotation from a publication from around 2016, 2014, 2016. And I think part of it may still apply in some settings. And one thing that is of vital importance is a vital role. Like it's an adjunct to our clinical exam and actually can make a difference between life and death. So this is why I felt this is quite important in a setting like this. So because of how intense we order imaging in kids with cancer, so you get a lot of requests from kids with childhood cancer compared to kids
Network problem.
from last year, 2021. They were looking at how can we actually improve access to medical imaging in low and middle income countries. And part of the problems that they highlighted on this publication is the lack of available imaging modalities. Number one, lack of trained personnel. Number two, and actually they were highlighting possible solutions to these problems, providing training and things like that. But I think it stems all from as other different conditions. And actually, a lot of healthcare advocacy comes from when you have sufficient evidence to say, I have numbers and I'm advocating for my practice to have this kind of imaging, or I'm advocating started said this platform provides an opportunity for people to publish, make research, and see how we can advocate more for these kids. So when we talk childhood cancer, there's an initiative that the WHO came up with. They call it the WHO Global Initiative for Childhood Cancer. And actually they have this booklet in their website available for public viewing. And their goal is to say, we want to move up the 20% to at least 60% survival by the year 2030. And actually their main objectives, they have two main objectives, of course, different other guidelines under those objectives. Number one is to capacitate different settings to provide quality services. And then number two is to increase prioritization of childhood cancer. And then they have many different guidelines underneath. And actually their projected target was by end of 2023, the initiative should be enrolled in up to 25 countries worldwide. I know a few African countries were the first to actually have this initiative enrolled. If I'm not mistaken, I think Ghana was one of the first countries, and it's actually a very helpful initiative. And this actually shows how childhood cancer is a burden, especially in the low-income settings. So when it comes to imaging, and I have a disclaimer. When I prepared this talk, I stumbled across guidelines from a hospital in the United States, and I felt the guidelines they had, they provided a good way to give an overview of this talk. And actually, a lot of the slides that I'll share after this one because the best way of going about them, looking at what we have in our settings. So when you think childhood cancer, the imaging can be as follows. Of course, I said there's no particular screening, but you can actually screen for populations that are at risk. You can screen for childhood cancers. And this screening is actually done in kids who do not have any signs or symptoms, but is more towards kids who have conditions or syndromes that predispose them to different types of cancers. Then you would have the initial staging. There's the imaging you do when to assess treatment response, and then the imaging you do as part of surveillance at the end of treatment. And then at the end, what you do for recurrence. But I have to say, once you have the initial diagnosis, the imaging recommendation differ from malignancy to malignancy, mainly because staging for different childhood cancers are actually different, and the treatment are actually different, and the treatment is also dependent on where you are in the world, what you have. I just highlighted a few syndromes here. Actually, there are a lot more, but these are the common ones that you may or may have not seen in your clinical practice. And these are clinical syndromes that are associated with a lot of malignancies. Number one is neurofibromatosis, 102, and these kids are predisposed to different types of brain tumors. A high prevalence of Beckwith-Waterman syndrome, and they actually have a dedicated clinic for those for Beckwith-Waterman syndrome. And this case down there. So if you have a child who has any of these syndromes, you may see them coming in and out of your clinical practice for recommended imaging. Most of them we image with MRI, but for Wilms tumor, you can just do an ultrasound and things like that. But many of them we do an MRI. Even those who have an initial normal imaging, you may actually need to do repeated imaging. Like for example, tuberous sclerosis, we do imaging every year until a certain age. So, so these are some of the things where you would have a lot of requests in your setting. And of course, there may be others as well. So in terms of sorry about that. In terms of the initial imaging when we have a suspected diagnosis. So what I tried to do, I tried to pick a few malignancies that are common in our setting here and did what we do to image them. And then the list is exhaustive, and then this is not the only thing that you do for them. And I think the reason why I pick different diagnoses is just to show or highlight that actually the role of imaging or the imaging requests are different from diagnosis to diagnosis. So leukemia is a hematological malignancy. So because it's hematology, we rarely have imaging requested. But one thing we need to know is it's a hematological malignancy that then spreads to the lymph nodes. So you can have kids presenting with mediastinal masses or lymphadenopathy or hepatosplenomegaly or things like that. So we request imaging depending on the presentation. So for kids who would present with a mediastinal mass, the first modality you do is a chest X-ray. And these kids actually sometimes they would present with a mediastinal mass that actually compresses their airway. But rule of thumb is if they have that mass, you need to evaluate the presence of the mass in all the other systems, commonly the chest, abdomen, and pelvis. So the treatment is in stages, and because the treatment is in stages, you'll repeat treatment. So if a child has a mediastinal, most centers would recommend a CT of the chest to evaluate the presence of that mass. But sometimes these kids, they would have that mediastinal mass compromising or life-threatening, compromising the your chest X-ray will be your ideal thing. And then if sometimes they have neurological symptoms, they can present with seizures, they can present also with a deposition of leukemic cells in other so sometimes, of course, they may would have present with these neurological symptoms and would have had an imaging from the emergency department or something. But there hasn't been any study to suggest that imaging has beneficial additional benefit in CNS leukemia detection or not. But the imaging, even though we image this mediastinal mass, the hepatosplenomegaly and all, staging for leukemia is certainly not based on staging. I mean, it's not based on imaging, but it actually has a different criteria, whether it's high risk or low risk. So a lot of low middle income countries, because of lack of resources to actually do proper staging, most of the kids, they are just treated as high risk. So if at all your child had a mediastinal mass, you did a CT scan. At the end of the induction phase, which is about 4 weeks, you would then do a repeat CT scan to see the response to treatment. If they have any residual disease, at every phase of your treatment, then you do a repeat CT scan. But if they had residual disease, then at every stage of your treatment, to see the response to treatment. So once they had residual disease and then you follow them up, once you start seeing no evidence of that mass, then the remaining surveillance, you can just do X-ray or an ultrasound to make a follow-up. And then during therapy, especially for leukemia, these are kids who receive very intense therapy. So sometimes they have complications, especially sepsis, that warrants additional imaging, even if they had imaging that is related to their diagnosis. But when they develop complications, they may need further extensive imaging. So commonly, especially for kids who develop fungal sepsis, most of the time, some setting actually, they recommend doing a whole body CT to look for fungal balls when they have fungal sepsis. So even if they had had that imaging in relation to the mass they had, if they have complications, different parts of the world. The most commonest solid tumor is brain tumor. Mainly for location and the ability to operate when managing these kids. One thing that points for, and I'm guilty of this, sometimes we just order imaging to radiology and we do not write requests that are convincing enough for radiologists and but numbers for any child, especially those less than 5 years, who present with a headache, is always a red flag. Who presents with any focal neurological signs or an abnormal gait is always a red flag. Just given analgesia and things like that, only for them to end up having focal neurological for metastasis. So because sometimes these kids will present with severe symptoms, especially declining GCS and all, have any other intracranial pressure that may warrant an emergency VP shunting. Case would come already with a CT access to an MRI. You would just go straight and do an MRI. But in an emergency situation, just get a CT scan, and then it may give you a perioperative consideration. The other thing is the imaging for MRI brain can give you a definite diagnosis, even without the need for biopsy, especially for low-grade intracranial tumors. And there's a WHO histological grading. So these tumors can actually be completely resected and then the kid is followed up thereafter. But if you have just bulk, you need to do an MRI. So you'd have a of your adjuvant treatment. And then thereafter, you do surveillance imaging. Most of the time, the first year, we follow them up for every 3 months, and they may require more frequent MRIs. I know a lot of settings do not have access to MRI. What I hear a comment that my internet is unstable. I highly apologize. And then for this grade 1 and 2, in the presence of spinal cord disease, with every subsequent MRI you do, you may consider doing spinal MRI as well, just to monitor for those metastases. So then after that, you can do it every 6 months or annually, depending on your availability of resource. I guess in this platform, we can have a discussion at the end to just to have an experience at what people do. But I guess these are the ideal recommendations. And then for high-grade gliomas, and these are 20%, 10 to 20% of the cases. These ones, they have very, very poor prognosis, even with complete resection and management. And actually, we are talking about life expectancy of about 3 years or so. So initial imaging, same as the low-grade ones, MRI before, after, and post-radiotherapy, and then upon follow-up. Surveillance for this one is not as intense as this one is quite intense compared to the high-grade ones. Some kids actually, if you do subsequent imaging and then you see recurrence, then they can be an indication for a second operation or a second resection, but that's dependent on the initial diagnosis and the location of the tumor. So the other common one is medulloblastoma, and it's actually a tumor that usually occupies the posterior fossa. These ones, they actually have a very good prognosis. You resect them, you put them on chemo for about 12 months and an additional radiation. But the issue, the problem most of the time is age. The younger the kids, the more difficult it is to do radiation for them. So chemotherapy is a bit for a long time. So immediately after the resection, you get an MRI post-op, and then to evaluate for residual tumor. And then you give chemo thereafter. At the end of the chemo, you do imaging as well to see the response to chemotherapy. If at all there is good response, then you follow them thereafter. But any sign of an enlarging tumor or recurrence, for those who had a good resection, it may be an indication for a second op. And then lymphoma, and I think a lot of publications around childhood lymphoma, you search online in different online libraries, a lot of studies in kids are actually from Uganda and Malawi. I think it has received a lot of studies, especially for resource limited settings. I have to acknowledge that their treatment approach is quite different as well. So lymphoma, basically, the basic understanding is tumor of the lymph nodes. It then spreads to the bone marrow. Two types, Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma is actually one that a child can stay with for a long time without actually progressing. But you see it initially, or you suspect it initially. Most of our kids, I don't know about other settings, most kids would have had an excision lymph node biopsy that come positive or suggestive. And then they get a CT scan of the neck, the chest, abdomen, and pelvis. Actually, you do a whole body CT. This guides your choice of treatment, and this guides the follow-up thereafter. So depending on how severe or the stage, there can be consideration for a PET scan. I know in our setting, we've referred some kids end of treatment for a PET scan to just evaluate recurrence. But of course, even in well-resourced settings, because of MULA, a PET scan is not routinely recommended, but sometimes you just have to go with our imaging. So not to bore you with a lot of details about Hodgkin's lymphoma, but this is the staging of Hodgkin's lymphoma. Now, this is one staging actually that is radiology dependent, depending on where you see the lymph nodes. You can see that actually depending on the location. So if I see a lymph node on the neck, I want to relate on the chest, I want to relate abdomen as well and pelvis. So depending on the extent, then you stage accordingly. And I guess you can see all the different stagings. So for Hodgkin's lymphoma, depending on the treatment that you use, these lymph nodes you just treat with cancer, and rarely do you need to go in surgically to remove the lymph nodes. You treat with chemotherapy, and then you evaluate response by subsequent imaging. CT scan is the main modality of imaging for response to therapy. So for stage 1 and 2, you just do a CT neck and chest. And for surveillance, you just do CT neck and chest, and then other areas depending on where else you saw them. And then thereafter, you can just do just a physical exam, a chest X-ray, and an ultrasound of the previously affected area. And then for higher staging, then of course, even at the end of therapy, you do the whole body CT again, neck, chest, abdomen, and pelvis every 6 months, and then every 6 months, first year, and then annually thereafter. But then if there is no sign of residual, then also your follow-up is just your physical exam, chest X-ray, and an abdominal ultrasound. But of course, for kids with inconclusive CT scan reports, that's where you need a PET scan for better evaluation. Non-Hodgkin's lymphoma is actually more aggressive than Hodgkin's lymphoma. And actually this one, they can present just like kids with leukemia. This is the one where kids can present with quite life-threatening emergencies, such as an SVC syndrome, airway obstruction, tumor lysis, cardiac tamponade, and all of those. So because of this, in life-threatening situation, you can just do a chest X-ray, an ultrasound, an echocardiogram. And at this point in life-threatening situations, usually you do not have anything to say there's a cancer, but you need to rule out other causes as well. But of course, if kids present with non-Hodgkin's lymphoma, they can present with CNS lymphoma, especially those who are immunocompromised. You can do an MRI of the brain. But the initial imaging is just like Hodgkin's lymphoma, and the surveillance depends on the staging. But it generally is just like the Hodgkin's lymphoma. Sorry. And there's also staging of is the Murphy staging of pediatric non-Hodgkin's lymphoma. It's almost similar to Hodgkin's lymphoma, but I won't bore you with the details. Just to say, it's also radiology dependent. And then neuroblastoma. This one it's one of the common extracranial solid tumors, either from the adrenal gland or from anywhere in the sympathetic chain. So actually presentation can be variable. So these ones, I put the staging here as well, just to say it's also image dependent when it comes to staging in your initial imaging. So you do whole body CT, sometimes actually an MRI as well if it involves the CNS. So the staging is quite variable, but all in all, when you simplify the staging, it can be very low risk, intermediate risk, or high risk. But the initial imaging, there's this MIBG scan, but these are for people with MULA. And I think a lot of people on this platform, they have more understanding on that kind of scan. But it's why it's a nuclear kind of scan, and it's actually quite sensitive. Hello? It's actually quite sensitive for neuroblastoma. And then, but In cases where you are limited, just the CT scan, abdomen, whole body CT scan to check for metastasis as well. So this one, because of the therapy, actually the therapy may be a bit long, up to 8 to 12 months or so. So actually you do a lot of imaging, but for very low risk and low risk, you can just do ultrasound scan at different intervals, depending on your accessibility of resource. Sometimes you can do it at the beginning, you just need that CT scan, and follow up, you can do ultrasound scan, especially if you have worsening symptoms. And then you do a CT scan again at the end of therapy, and then you follow up from there. And then those who are on chemotherapy, you do a CT scan at the end of chemotherapy as well. Low risk and high risk, sometimes they may not get to a point where they need a CT scan. This tumor, sometimes they okay, and then they disappear with age. And then Worm's tumor, another common one. This one actually, with a very good and experienced radiographer, you can make a diagnosis on just abdominal ultrasound. But then the key thing is you still need a whole body CT. There's a cancer that usually metastasizes to the lungs actually. So you also need a CT, chest, abdomen, and pelvis. So depending on treatment, this one, the treatment, some people will operate before chemo, some people will give chemo, operate, and then do chemo again. But depending on treatment, for us here in our setting, what we do is we do chemo 2 cycles, and then we take for surgery. In that regard, you do your CT scan, and then after the 2 cycles, you do another CT scan just to evaluate the response to chemotherapy of the tumor, and then you take for surgery, and then continue chemo, and then follow up again as part of your surveillance. And then the post-op, after your surgery, after your chemo, you can just follow up with just an ultrasound and a chest X-ray, unless or otherwise a CT scan is indicated. And mainly this is when you have recurrence of the tumor. So rhabdomyosarcoma, I think this one carries the highest mortality. It's a tumor arising from skeletal muscle. So any skeletal muscle in the body. So you can imagine can present any part of the body. So the initial imaging depends on the primary site. So the staging is just like the adults where you do your TMN staging, but most of the time, just do a CT scan for metastasis. You do the abdomen, the pelvis, and the chest as well, depending on the location. So if it's arising intra-abdominal, you can opt for CT or MRI. But if it's arising from the thoracic cavity, CT is more preferred, provided that it does not come from the chest wall. And then if it's arising from any other anatomic sites, an MRI. So most of the time, because the only thing you have access for is the CT, it's sufficient enough and you manage depending on that. You may need to restage during treatment, but most of the time we just repeat imaging at the end of therapy. So for these ones, follow up as well. It's for, you can just use ultrasound and chest X-ray. So like I said, these kids, we follow them up. For most cancers, you follow up every 3 months for the first year, 6 months for the second year, and annually thereafter. And other imaging, we usually recommend echocardiogram, especially for kids who are on any anthracycline therapy. So we do echocardiogram. So the echo is recommended before any treatment where you anticipate that you use any anthracycline. And then you do it at the end of treatment as well. Sometimes it can be more frequent depending on the initial findings. And of course, the exceptional cases, I've seen one kid who had a Worm's tumor that actually extended into the right atrium. So these are cases where you actually may need to do echocardiogram, and these are exceptional cases, but it's vital. So all in all, these are my general take-home points to say there is no running away from radiology, especially in childhood cancer. because the subsequent imagings, you just need to compare with your initial imaging, whether it's ultrasound, X-ray, or CT scan. When you do subsequent imaging, you need to compare with the previous one and interpret based on what you found on the initial one. I think I was following up a kid with David, who had non-Hodgkin's lymphoma. He had a very extensive disease initially. And the way he had a relapse, he just had a nodule on the scalp and a testicular swelling. And I think at the time when David did second imaging, he requested imaging from before. And a lot of signs of relapse were not visible actually on the initial imaging. So I think it's always good to say, if you have a child, then also follow them up. There's certainly limitation to resource, to access. And I think radiographers and radiology in general, they're quite overwhelmed with resources. I'm here advocating for childhood cancer. Someone will be there out there advocating for pregnant women. Someone will be there advocating for neonates or whatever the reason may be. But I think all in all, in a setting where there's treatment for childhood cancer, you'd have a lot more requests. Sometimes they don't even make sense. And this is where I feel radiographers, radiologists can be advocates, need to work more with people who manage childhood cancers. We can share ideas, share knowledge, and have a discussion. I know some simple biopsies, especially for relapses, such as a simple intracranial scalp or a simple node, we can do an ultrasound guided biopsy and all. And that's where we need radiology. And I think there's no running away from the need for research, to influence policy, to influence resource mobilization. And I think all in all, I just wanted to share that with you. Certainly, there may be people in this platform who have more experience than I have in terms of managing kids with cancer and also following them up. And I think I can open the floor for questions and also for discussions in terms of people's experiences, people's what they have in their settings. So thank you for your time.